Uh, my name is Bruce Lian. I'm the Dean of UConn School of Medicine. Uh, and we welcome you to the third and final panel on COVID-19. We are going to talk about UConn's success stories in the hospital, in the clinic, and the schools. We have truly a very distinguished panel. I'm not just saying that every time, but this is really truly distinguished. And I'm going to stop here and ask each of the panelists to introduce him or herself. First up, we have Carol Ryan.
Hi, everybody. Good evening. Very happy to be able to be part of this panel. I have been at, I am the Chief Nursing Officer and Vice President of Quality and Patient Services. I've been at UConn for 35 years. My background is adult critical care, and then I have worked through management and directors of many of the units that we have here. It has been a great, tremendous experience to be part of UConn for as long as I have. And it has been I have been very proud and honored to serve as the Chief Nursing Officer here. And the last year has really just been a great reflection of all the work within the leadership and the staff and the patients within UConn Health. And it has been really rewarding. So thank you.
Thank you, Carol. Look forward to hearing your discussion and experience. Next, we have Dean Lepowski, Dr. Lepowski.
Yeah, good evening, everyone. I'm Stephen Lepowski. I'm very proud and pleased to serve as the Dean of the School of Dental Medicine. I've been here at UConn Health for now 28 years in a number of different capacities. And I echo Carol's comments that this has just been an incredibly rewarding experience during the pandemic to see people rise to the occasion and work together to serve the communities that we serve and to continue to educate students and residents. So very happy to be with you tonight.
Thank you, Dr. Lepowski. Steve, last but not least, Dr. Rob Fuller.
Hi, good evening, everybody. I'm Rob Fuller. I'm the chair of emergency medicine. I'm an emergency doctor, and I've been at UConn for a good 20 or 30 years. I don't know, I don't count anymore. As an emergency doctor, I had an excellent experience previous to the COVID pandemic with other disasters. I was privileged to be able to respond to disasters around the world in Indonesia, in Haiti, in Ecuador, in the Philippines, and other places. And so I brought some of my disaster know-how, as well as my emergency medicine know-how, to the game as we were getting ready for our COVID response and working with the hospital team to be able to respond to COVID. And I too am very proud of the folks I work with during this, and the students that we get to keep working with, the residents that we get to keep working with. From day one all the way through the pandemic, the emergency department continued to have. So it's great to be part of that team, and great to have the support of Dean Liang. So that's me.
Thank you, Rob. So everyone, if you want to think back to about a year ago when we faced this pandemic, truthfully, here at UConn Health, speaking from my personal experience, I didn't know what was going on. I didn't know what hit us. Totally caught blindsided. But in the last 12 months, just amazing, if not miraculous development. First we have an antiviral drug called remdesivir, which does shorten the length of hospital stay that was approved. We have then the experience out of United Kingdom that an old-fashioned drug, which has been around for a long time, called dexamethasone, can actually cut the mortality of severe COVID cases. And then who would imagine in less than a year you have a vaccine that was developed? Not only that it was developed, but the first two are 95% effective, which is just amazing because we know about the flu vaccine everybody gets every year. The flu vaccine is only about 55, 60% effective. But here we have a vaccine against this deadly virus that's 95% effective. And there's no doubt that this is a game changer and that it allows us to go back to normalcy. We're not quite there yet. We're pretty close. So I believe the guidance coming out of the governor's office and the state are the right one, that we still need to exercise precautions, keeping the mask on for a little longer. But I think finally we see the light at the end of the tunnel. But we got to keep going. We don't want to go backward. And but today we really want to hear from the distinguished panelists here on their personal experiences at the front line dealing with patients with COVID-19. So first off, we have Dr. Fuller. So Rob, we hear a lot about the emotional toll on healthcare workers. How did you and other leaders in the emergency department, for example, recognize and then prevent and help with, the emotional toll that they experience during this pandemic? So please share your experience and story.
Well, there's a piece of being in the emergency department where you're used to having hard days and telling bad news as part of the usual course of business. But the pandemic certainly made that amplified. There's more acute illness, and then you don't have that person-to-person, face-to-face contact with the patient's family to help them navigate the emotional toll that they're having when their loved one's ill. And that's hard for nurses and doctors to deal with, that inability to have an emotional bond with the family that's suffering when someone's ill. And then the team themselves, at the very beginning of this, we were like Dr. Liang mentioned, we were kind of going to this a little bit blindly. We didn't know how safe we might be while we were wearing the PPE that was provided to us. We didn't know how contagious this might be. We didn't know how risky it might be to ourselves and to our families when we went home. And so it was a real burden to have the preoccupation of your own health and safety beyond the normal risks of being in healthcare. And then this increased illness that we're facing, and then the inability to help the families navigate the illness in person. All those challenges, plus the duty hours that we faced at the time, really tends to wear people down. And I think some of the things that Eileen Scully, who's a recent winner of the Nightingale Award and an excellent partner of mine, she's the nurse manager in the emergency department, Dr. Phil Licciardi, who's the medical director, and myself, the three of us as leaders made sure that we did certain things every day with our teams. We always showed up in person. So we met them at work. We always were there. One of us leaders was there at every shift to tell them about how we were working with them to keep them safe and what the game plan was for the day, because the game plan kept changing. Now, the rules are different from day to day virtually. We could answer their questions in person. We could gauge how they were doing, which helped us maybe give someone an easier assignment, be sure that someone had a break, be sure that someone had food or coffee, or even just talking to someone if you could see that someone was stressed and crying. You could take them aside and let them debrief a little with you. So one of the three of us were always having our hand on the throttle of how the department was doing emotionally. We also had some great support from outside. I think it was a board member or a foundation member who reached out to the emergency department and said, "How can we help you through this?" And my request is pretty simple. We wanted a water cooler, like it was that easy, and like a magic wand. And then suddenly we all had, you're breathing in these masks all day, and suddenly we had a water cooler in our conference room that we could, fill up our water bottles and get hydrated. We didn't need much, And then some of the community would reach out to us and say, hey, we want to support you guys. And they would, a pizza restaurant like Naples in Farmington started calling us up and saying, hey, we want to send you guys some pizzas. I know you're working hard. And so there'd be like this time to break, find some space, get some calories, and recenter yourself. So simple things like food and water and a careful gauge of how people were doing, and then leadership being there, walking the walk. I worked every single day during the worst of the pandemic. I was there every day at work, but walking the walk with my colleagues, with my nurses, with my medical assistants, really helps show them that you're there for them. So that's what we did, and our team came through pretty well. Bruised, but better for it.
Thank you, Rob. I would, safely call you and all of you heroes, healthcare heroes. And so we're very grateful for what you and everybody else has done for the community and for the patients at UConn Health. So I got one more question, or two more actually questions for you. So as an emergency medicine physician, you saw sort of a mix of, minor and major medical conditions before the pandemic. And then when the pandemic came, there were changes, right? So how did you and your staff adapt to the changes? Were there any change in the treatment of emergency medicine patients that came during the pandemic?
There were, and like, again, some of these changes, you're making them on Monday, you think you need to change, and by Tuesday, you need a plan in place to do it. So things would move really quickly. But an area that you know very well, Bruce, acute heart attack kind of presentations. We have an excellent system at UConn Health with some of the fastest times in the state from presenting to the department by ambulance or by the front door and getting seen in the emergency department and getting up to the catheterization lab where we can do advanced techniques to open up a blocked artery. Rock and roll fast, 20 minutes, kind of break the sound barrier kind of speeds. However, when the patient has COVID, that whole treatment plan has to come differently. You need to stop, move the patient to a special room. Everyone needs to get gowned up. And maybe the intervention is more dangerous in the face of COVID with its extra coagulation risks. And so we had to change gears, and we switched to more medical therapies rather than surgical therapies for heart attack patients when there's a high risk of COVID. And we changed the way our patients flow through the department. And that's just one example. We had to do the same thing for strokes. We had to do the same things for pneumonias. A community pneumonia that would have come in November before the pandemic started was managed in a certain way. And suddenly in March, a pneumonia is a whole different disease because it's this viral pneumonia which we manage in a different manner. So we were readjusting the ways we approached all of the usual cases, as well as when the blend of COVID cases started coming in, trying to mix the two together. The community had to do the same thing. Ambulances had to make some pivots. And as we lead some ambulance services and how they deliver care, we had to help them understand how they could manage differently. Even things as simple as appendicitis, which traditionally, until this past year, I've never seen an appendicitis that wasn't managed with an operating room, except maybe if it was already perforated and maybe a drain would be placed, another small procedure. But when the pandemic started, we started treating appendicitis that were mild with antibiotics, without surgery. Because again, we had to change the treatment plan because surgery in the face of COVID is more dangerous than it is when COVID's not around. And so we would keep people out of the operating room and treat them with antibiotics and cross our fingers. 6 out of 10 times they stay better, but sometimes they get sick again. So those are some examples of some changes we had to make. And they were really made in a very short amount of time with a lot of thoughtfulness and great insight from some expert colleagues in all areas.
Great.
That's not too technical, right?
No, I think you hit it right on the US hospital system really adapted it by decreasing all the elective procedures and the usual things, and people stay away from the hospital, even die at home because of heart attack or stroke, as you know. So what about on the positive side, Rob? Is there anything that you saw a silver lining as a result of the dramatic disruption and upsetness that the COVID has caused in the medical world? I mean, are there any silver lining? Are there any positive things that we learned or we did from the surge?
Yeah, like everything, what you survive makes you stronger in some ways. I think there's a German saying that goes like that. But it's there were some flexibilities that were forced upon us as an institution. You get kind of used to doing the way you're doing it, and changing something the way you do it is really hard. But suddenly there's a storm and you have to actually change it, and everyone pulls together. And one silver lining, I think, on our campus was all of the leaders and unit managers, and even in the folks that report to these unit managers, we all felt like we were pulling on the same team for the same cause. And there was this unity that we had that was just, fantastic. It's like a big snowstorm where you go help your neighbor shovel, and then you maybe haven't seen your neighbor for 6 months after that, But it was like that kind of thing where there was this unity that we had, this singular purpose of taking the best care of patients that we could, and keeping our staff, our students, and our residents safe while doing that. That singular purpose was really a silver lining. And then I think healthcare in general in the United States saw some really big advances all of a sudden. Executing telemedicine was virtually impossible for us as a country because of the insurance bureaucracies and some concerns about quality and concerns about communication, concerns about access, and those things still exist. However, COVID forced us as a country to take a huge leap forward, probably a decade forward, in using the electronic communication tools that are available to us to take care of patients at distance. I don't do that because I'm an emergency doctor, but many of my primary care doctors and specialist colleagues can touch base with their patients now remotely and help guide them through their illness without having them come into what might be a dangerous environment for them back before the vaccine was available and when cases were high. A huge silver lining. We can't say it didn't happen. So there are probably others out there too.
Hey, Rob, you and your people have been at the very front line. That's the first stop when people have any symptoms, they come to you guys. So certainly at some risk for contracting the virus. I know some of the staff have. But did anybody got seriously ill? And if they didn't, you think that's because of the protective personal gear?
I don't think we had any confirmed exposures from patient contact. We took care of many. Every ill patient came through with COVID to the hospital through our doors, and then we sent home 10 more for every one that we admitted. So we saw lots of COVID patients, and I don't think any of our staff were infected by patient contacts. We did have some people become ill because of contact with their family or friends, or even with a coworker over a coffee somewhere, they might have become ill. And we did have a few people become quite ill. Thank goodness nobody died, and everyone's back to work again from our unit, which is really wonderful. We did have a few people quite ill, and a couple of our members even ended up in the ICU for a while in our hospital getting care.
Thank you, Rob. Appreciate it. And stay where you are. We're going to come back to you, and there might be very good questions for you. Next, my pleasure to ask Carol Ryan, our Chief Nursing Officer at UConn Health. Just a few questions. So Carol, what did you view as the most significant challenges you faced as the Chief Nursing Officer related to the first COVID-19 surge?
Well, I actually took over as the CNO in November of 2019. And so really it was just about getting my feet wet. And all of a sudden, as I think you described, Dr. Liang, in a matter of a day, we were almost, the change came over like it was a tremendous change. It was a complete, circle that we were like clinics were closing, the ORs were only taking urgent cases, and that was the mandate from the state. And so, I remember thinking to myself, wow, okay, we need to get into gear. And I remember thinking that the most important thing to me was safety. And it was almost like Dr. Fuller was saying, we have to think of patient safety, staff safety. Do we have enough PPE? How am I going to staff the ICU? I think that the environment was also a concern. And how are we going to manage the environment? Luckily, we have a brand new university tower that is 4.5 years old. We had the ability to biocontain. That means to really seclude units and to make it all negative pressure. So basically the staff would wear one PPE outfit, in and out of different rooms, and they would not have to change. And so we actually had biocontainment units on 3 of the units that we had, the ICU, the intermediate unit, and even our medicine unit, we totally biocontained. And so I would say that safety was my first concern. Staffing was my second. We had an ICU that was bursting at the seams with, 25 patients, and we needed to take care of them. Many of those patients needed 3 nurses to take care of them. They were on, a good majority of them were on ventilators. We had to turn them and prone them. We'd need about 10 people to prone them. So I had to make decisions pretty quickly about staffing. And we took all of the staff from the PACU. We took staff from the OR. We took staff from the clinics that had an ICU background, from cardiology, from pulmonary, and we pulled them all up to the ICU. It was a tremendous effort, extraordinary amount of collaboration, and not one individual staff member said, I can't do it. They all stepped up. When I think about it, I get really passionate and emotional to this day, because every one of them stepped up, and they worked days, they worked nights, they came in on weekends. They were just tremendous. They were true heroes. We had a individual, 47-year-old, actually he's been on TV, Jeff Martindale, worked for ESPN. And he came in the first phase it was probably the 3rd week in March. He was one of our first patients. Within 10 days, he was put on a ventilator. I think his hospital stay was somewhere between 21 and 23 days, and was very close to death. The staff, I remember that, and remember, we had no visitors. So the families really were not coming in to see the patients. We had to work with iPads, and we did a lot of FaceTiming with families. The nursing staff was right in there trying to make sure that the families were informed. And Jeff Martindale, he walked out of our hospital, 23 days later, and he now, a year later, has really described his experience as just extraordinary effort from the healthcare workers and the heroes in the ICU. 3 different nurses were on one of the channels with him doing an interview. The family remains very close to the ICU staff, and truly a success story, of which we had many.
Thank you. That's really, really heartening to hear, and very touching, and I appreciate hearing the story from someone who was there, taking care of patients like him.
Mhm.
The first pandemic surged somewhere in the middle of April of 2020, and then we kind of had a lull. The number went down during the summer month. And then in the winter, particularly November, December, and January, we experienced a second surge. What were some of the major similarities and perhaps more importantly, differences between the 2 COVID-19 surges?
And they were very different, Dr. Liang. So the first surge and we had probably the same number at any one point, the height of the pandemic of each surge. We had probably about anywhere from 55 to 58 patients at one time. I think the first surge was about 50, somewhere around 58. I think the second surge was probably around 52, 53. But very different. So the first time around, we had very few staff that were ill. We had, as Rob, has described, we had some people that were infected from, community, from, either their father, mother, brother, sister, husband, wife, but very few. The second surge, we had staff going down, multiple staff every day. I would turn on to my email and I'd see 10 more staff that would either be positive or would have to quarantine. And the staff were not getting infected at work. It was really, in the community. And I forgot to mention this, but during the first surge, not one ICU staff member contracted COVID, not one. And as Rob said, the rules were changing every day. We were trying to make sure that they were protected. The second time around, we just had so much community exposure. The hardest thing was and it was a different surge. The first time around, we had a lot of sick patients, COVID positive in the ICU. The second surge, the ICU had patients, but at a much lower number. The majority of patients were in the intermediate unit and also in the medicine unit. And so that was also a very big difference. So really operationalizing what was happening and how you could really monitor the staffing and monitor and making sure that you were keeping people safe, and the testing, quarantining the majority of staff was very, very different. And the second time around, we were open for business. So the first time around, our clinics were closed. We were doing only urgent surgeries. The time around, we were ramping up because financially we needed to, turn our finances around, since we had lost, almost $61 million million dollars through the COVID period. And so we were trying to ramp up to really make up for that deficit. So the second time around, we have a busy OVAR, we have biocontainment again, we have our staff getting sick, and we're trying to, really keep going forward. So that was probably really, as far as differences, very different periods, very different surges, and to really look at this new norm and have a second surge that was already in the middle of a very, very busy hospital.
So there's some positives in that sense, that we know how to deal with it, and the patients were less sick. And we were able to open the regular non-COVID care, so people don't have to be afraid of coming to the hospital, because it is a virus safe, not a virus free, but a virus safe environment. So they can get their acute care, such as a heart attack or stroke or other more urgent procedures. So Carol, we may be very close to getting back to some normality or normalcy. And what do you think are some of the challenges on the one hand, and maybe opportunity related to a new norm, maybe not completely normal after the second surge? As you know, we're down to what, three patients in the hospital now, compared to 40 something during the second surge peak.
Right.
So can you share with us your thoughts?
I think that in this new norm that we're now seeing, it's really trying to stabilize our growth, really look to, growing now and moving forward, where we were in 2019, which we were on a great trajectory, and then, growth trajectory, and then COVID hit. So now we're trying to really get back into that. Units like our epilepsy monitoring unit on the third floor that really had taken a hiatus over the last year, we're now, up and running. We have really been able to work. I don't think I mentioned this before, but on one of our units that was actually a surge unit, our University Tower 4, right now is closed, but we do administer monoclonal antibodies there. So as we're, infusing, for the patients that are now COVID positive and coming in for these infusions to really help their course of their disease process, I should say ease. We're also very actively looking at how we grow our programs. And I think that we've looked at, the OR, we are seeing, and I hate to even say this out loud, but we are seeing a slight increase in some of our staff through community exposure in their families becoming positive again, just over the last, I would say, week and a half. So I'm hoping it's not as much variant, but just hopefully just situational, and we won't see an increase right now. The great news is that right now, we've been able to get, I would say 70 to 75% of our staff vaccinated, which is just incredible. When staff received that first vaccination, and you saw how strong they became, because they just felt that, wow, this is going to probably end. Hopefully this will end. So I think there is, even though there is still, you can still see the staff that, they're still tired from last year. They're still, looking at, the future saying, wow, are we really going to see, are we going to really see the end? So I think through the vaccines, we've seen a revitalization of the staff. They're really, more positive and looking at the future. So I think that is really a big difference. I think the more vaccine that we give, we're also, I think, as I mentioned, the fact that we have been giving the vaccine here to also the community has also been a great marketing tool for us, because they come on this beautiful campus and they say, wow, do you have a primary care physician I can see here? Which is just, it gives us, I think, a lot of hope for growth in the future and stabilization. I think, unfortunately, there are some nursing staff that have really been, really have recognized that they may need to take a break, and have left from the ICU, have left critical care for a little while, because the last year has really taken a toll. And we've seen this across the nation, across the state, across the nation. And we really have been also put a lot of effort into HR and, employee assistance in different programs where they can, have some either group discussions in a unit or individual discussions to really talk through the last year.
Yeah, very, very touching. And thank you again, Carol, for all that you do here. We really appreciate it. And more importantly, the patients really are safe, and appreciate all the wonderful work you and the nurses are doing. It really, they kept all the patients alive. I mean, that's really true. And
You did a
so we
great job.
thank you
Thank
for
you.
doing that. And don't go away, and because we'll come back to you for our questions. And so the next speaker is Dr. Lepowski, Dean of Dental School. So Steve, last year CDC actually advised that the dentists temporarily stop seeing regular patients. How did the School of Dental Medicine respond to this recommendation?
Yeah, actually today marks the exact 1-year anniversary that both the CDC and the American Dental Association made the recommendation that all dental practices postpone elective procedures. And they did so initially to help mitigate or just slow the spread of COVID-19. But even at that time, the emerging science indicated that coronavirus was spread through the airborne route. So there was significant concern that coronavirus could be spread through the aerosols that we produce during most dental procedures. So we at the school actually made the decision to temporarily stop seeing regularly scheduled elective ongoing visits the week prior. because we saw some trends that were going on in the country, and then limited all of our patient care activity to the management of dental emergencies only. We shifted quite a number of our resources to be able to expand our capacity to see emergency walk-in patients, because we knew that not only some of our patients would not be able to get regular care, but also patients throughout the state. We needed to contact all of the patients that were already scheduled by phone, by mail, by web, and then discuss with them a plan to reschedule appointments, but for some time in the future, because we didn't know when it would be safe to do so. And then day by day, we started to completely reevaluate and assess both our physical facility and all of our patient care protocols, fortunately using some available guidance from the CDC, the ADA, and the Department of Public Health. So incrementally, we wound up modifying all aspects of our clinical care system so we could reestablish ongoing non-emergency patient care, which we did at the beginning of June of 2020. Since that time, we had to continually modify and adjust our approaches almost weekly to ensure that we were always able to provide our patients with dental care and at the same time train our students and residents, but in the safest way possible. And in terms of health, safety, and well-being, it was not only of our patients, but also our students, residents, faculty, and staff. And I'll share with you that our faculty, our staff, our students, our residents, everyone within the school community were really outstanding partners in making this happen. We had times at the beginning when we had curtailed a lot of activity and we're focusing on emergencies that some of our staff and some of our residents and faculty volunteered to do things in other parts of the health center to pitch in, which was really outstanding.
Thank you, Steve. So you touch upon this, looking back to a year ago and now, can you reflect on some of the changes that are happening in the practice of dental medicine? Some temporary, and maybe some of them will continue to be so.
Yeah, certainly. I mean, in some ways, much hasn't changed in terms of the actual care being provided. The greatest change has been in the environment in which the care happens and the protocols and processes that everyone follows. So all members of the dental team now wear much more personal protective equipment than ever before, masks which have a much higher filtration rate than we used pre-pandemic, face shields and other things. Appointments have become a little bit longer and in many instances a little bit more spaced out to allow for higher levels of disinfection, lower occupancy in waiting rooms, things of that nature. We, like many dental centers, added additional devices and equipment to help clean and filter the air better, again, because of concern for the aerosols that we produce. And these were all efforts to significantly reduce the potential spread of any aerosols. We also started the regular use of a number of different oral rinses to hopefully aid in the reduction of both bacterial and viral loads in the oral cavity. Something that Dr. Fuller mentioned, a major change is the growth of teledentistry in dental medicine. I mean, we implemented the use of teledentistry during the first few months of the pandemic when we were limited to emergency visits only as a mechanism to help identify which patients needed to be seen, which needed to be seen on an urgent or emergent basis. So it was very beneficial in triaging patient needs and also helping our patients who didn't have a true dental emergency manage their needs at home until we could see them for ongoing care. We're now working on significantly expanding our teledentistry capacities to further increase access to care because of the incredible response that we got from patients. And we were able to identify different ways to improve access to dental care. So that was one of the benefits that came out of this.
Yeah. So, you know, as Rob was saying, and as Carol was saying, I mean, we did learn a lot, and some of this is going to stay after the pandemic is over. which we hope will happen soon. So as a patient, is there any safety concern to be seen by your dentist faculty during the pandemic? Did you hear of any questions? Is it safe for me to come in and be seen? Because, I know the procedures is going to generate some aerosol and things like that.
Yeah, I mean, absolutely, it's safe. It's safe now. And I think it's safe now because of all of the different steps to mitigate risks to patients that have been implemented. I mean, dental providers have historically, we've been very attuned to infection control. So many of us, the modifications that were needed was able to be adopted fairly readily. But I mean, I absolutely encourage patients to seek dental care, as oral health is critical to overall health. And there's concerns that delaying dental care can result in an increase in the severity of existing dental problems. We've also been seeing an increase in the frequency of cracked and fractured teeth, possibly due to the stress that we've all been experiencing during the pandemic. We made a concerted effort to make sure we communicated to our patients the steps that we were taking so that patients would be comfortable coming back to have dental care provided. And I think patients will likely see the changes that have been implemented because they're very, very evident. I mean, it's front and center. And I think our patients have been very, very responsive to the changes that we've made, have understood the additional steps that we're going through to ensure their safety, health, and well-being. I mean, I can tell you, I'm very, very proud of what we were able to accomplish in the school and what we were able to accomplish in the time frame that we were.
Great, thank you. Speaking of the School of Dental Medicine, how did the school continue to teach students and your residents as well? These people who already have a DMD or DDS, a degree, who become a resident doctor.
Yeah, at the same time that we needed to alter all of our patient care operations, we had to do the same for all aspects of our educational programs, as did you and your colleagues in the School of Medicine. So we pivoted virtually all of our instruction from in-person to online in a matter of a few days. The biomedical sciences curriculum, which is shared between our two schools, shifted to primarily an online delivery again within a few days. We took a critical look at student calendars in each year because we knew that with the ramping down of clinical activity, students wouldn't be seeing patients to the same extent that they had been, particularly for that period of March through May. So we shifted classes that would have happened later in the year or even in a subsequent year to use that time that became available because of changes in our patient care delivery. And that was done intentionally so that when we were able to resume patient care, there was more time available for them, because it was important that we took whatever steps were needed so that the pandemic wouldn't adversely impact the education of any of our students or residents. The residency programs took similar steps to maximizing those learning opportunities. And I mean, honestly, our faculty were tremendous in working very, very hard to adjust and modify their courses and the sequencing to accommodate very, very new and different and sometimes very unfamiliar ways to teach. And our students and our residents were just incredible in terms of their flexibility, their resilience, and their dedication to continue to learn. We have learned through this process that there are some different ways to engage and interact with students and residents. And I think that many of the modalities that we had to implement out of necessity because of the pandemic will be with us to stay, because we've learned some things that have shown us different and even better ways to do some of the teaching.
Great, thank you. So the last question has got two parts to it. One is are there dental or oral manifestation of COVID-19 that your researchers in the school have seen? And then connected with that, the second part of the one is, any COVID-related research, whether it's an oral manifestation or not, that your faculty have been doing.
Um, um, Although there have been multiple reports of oral manifestations of COVID-19, many of the studies have not really been verified, and several of those reported cases wind up that they're actually normal variations of other non-COVID related oral or dental conditions. But there's still quite a bit of work and research currently occurring to further investigate that question. I think it's still very early in the process to know. To date, we within the school have not seen any specific conditions or issues that can be directly correlated or associated with COVID, except for issues that may have been pre-existing that got worse because of the delays in treatment. But a number of individuals and groups within the school, but not only within the school, but also working across the health center and across the university, are engaged in COVID-related research. I'll share with folks that one of the most exciting projects was led by Dr. Chang-Chung Liu in the Department of Biomedical Engineering, which I don't think many people are aware that we do have within UConn Health, the Department of Biomedical Engineering, and it's in a department that's shared between the School of Medicine, the School of Dental Medicine, and the School of Engineering at the Storrs campus. But Dr. Liu and his colleagues worked on developing a technology to readily identify not only SARS-CoV-2, but other viruses using some very simple and readily available tools that could potentially lead to testing being done at home. And just recently, that technology was licensed to a commercial company who saw a promise in the ability to take it to market and advance the ability for people to test, again, not only for COVID, but for a number of other diseases that are caused by viruses, including HIV.
Wow, exciting, exciting. Thank you, Steve. Again, please stay and don't go away. I'm going to wrap up by just telling the folks some of the updates in the medical school. As Steve mentioned, the preclinical rotation, we adapted the online learning, and then we adapted it to a hybrid curriculum so that some students are actually returning to the campus, learning in person, in conjunction with remote online learning, and that has actually gone very, very well. We were able to use some of the telemedicine, telehealth technology to enable not an in-person face-to-face, but a virtual face-to-face teaching. And that is something we didn't expect, but actually was quite effective. The clinical rotation students, that is the third and fourth year students, actually returned in full force to the clinical sites in June of 2020. So they didn't miss much, and they are just as well trained clinically. And the fourth year students will be graduating in about a month and a half. So they are just as well trained, and they're going to be part of the healthcare providers and fulfill their lifelong dream to become a healer and caretakers. So we're very excited about the graduation that's coming up. No compromise to their clinical training. I can guarantee you that. In terms of some of the research that the medical school faculty has conducted, I'll just name a few. In collaboration with the Jackson Lab, they developed a way to quantify the amount of antibodies that's produced that can actually kill the virus. So it's not just yes or no, you have the antibody against the virus. It's actually, you could tell how much you have that can protect you from the virus should you get the virus. So that was then applied to our healthcare workers that everybody who got infected developed the antibodies. That's the good news. The not so clear news is that the antibody levels did go down significantly with time, maybe to a third of its original level. And which is why we want everybody to get vaccinated, because you don't get enough antibodies from the infection. The vaccine will give you the boost that's needed. And the other research we've been very excited about is a collaboration with a faculty in the School of Engineering, who's developed a handheld instrument that can take a few drops of the blood and tell you whether or not you've been infected, right? So no nasal swab, no saliva spitting, no PCR testing. And so just from testing a few drops of the blood, because the blood cells change their shape if they got infected. This result could also revolutionize the way we diagnose COVID-19 infection, especially in rural America. This new technology developed by Dr. Baran Javadi at the School of Engineering could be extremely helpful. And so I'm just going to give you some of the exciting research that our faculty is taking advantage of this environment to produce cutting edge research. So with that, I think we're done with today's panel, and we're here. We've got a few more minutes and happy to answer any questions you may have. I think the way I was told is that you could type your questions directly into the question and answer tab that's available on your Zoom. So I have a question. Oh, yeah, they asked, okay, let me see if I can open this up. Okay, to get started, I have a question for Carol. Carol, so there was a community spread that impacted on the staff. Now 75% of your nurses are vaccinated, roughly. So what do you think, you know, going to the summer, maybe after the summer, going to the fall, the winter season again, if you have a crystal ball, what do you think is going to happen? Are we going to, you know, and also we have these variants, which is 50% more, you know, infections. So what do you think about that?
I'm hoping we can have a booster shot by then, and we can get everybody prepared. I think I would think a booster shot is probably inevitable. I think that, I know that the two major vaccine producers are, I think Pfizer and Moderna are both looking towards that. I think that as we progress, every day I'm getting more staff that may have, of that 25%, that may have hesitated before, but now are getting, I would hope that we're going to be closer to 100, over 90% of all the frontline staff that have been immunized. And hopefully, the more that we see our community and our staff vaccinated, as the governor's opening up everything as of April 5th, hopefully we can develop herd immunity, and hopefully those variants, if people get sick, if staff and community get sick, it will not be as severe, and hopefully that will hopefully end that surge. I'm hoping that we don't go into another surge. I'm just a little hesitant to say that right now.
Okay, well, thank you. I'm seeing some questions in the box, question and answer box now. Jane asked the question, would the new home blood test be able to detect past COVID infection, say from about a year ago, or only the recent ones only? So Steve, you mentioned this home blood test, and then we have the antibody test, of which I mentioned that the quantitative assay to measure the protective antibody. So Steve, you want to go first there?
Yeah, sure. The technology that Dr. Liu developed would be able to detect past infections for a fairly extended period of time, not just recent one. In terms of when would it be available, that I don't know. But I know that the industry partners that his group is working with are certainly excited to try to bring it to market as quickly as possible. But I unfortunately, I don't have an actual date.
Right. So the antibody test, the level does go down as you get away from the infection. The longest time we have follow-up after the infection is about 7.5 months. We still see a significant amount of these so-called neutralizing or protective antibodies. So Jane, I think there's some level of antibodies there. It tells you that you had an infection before. And what we don't know is how protected you are from a relatively reduced level of these protective antibodies. And if you get a vaccine, I'm sure that the level will go right back up. And if you didn't get the vaccine, you may be at risk for getting reinfection, which would then cause a further boost in the level of these antibodies. And so those are very, very good questions. And we actually actively looking at it right now. One study we are doing is to take people who got vaccinated at 2, 4, 6, and 12 months later, measure the amount of these protective antibodies, because the question is how long would the immunity last, and when do we get a booster shot, for example, once a year or once in 2 years, or maybe never. I don't know. We just, these are the things we are learning right now through the active research we are conducting. And Jane, you also have another question. What would you do if you're allergic to an mRNA vaccine? Well, there's some good news here. So Jnj is not an mRNA vaccine. It uses a vector, adenovirus vector, that carry the spike protein gene in the COVID-19 virus. So that one doesn't have an mRNA or the so-called the vehicles that package the mRNA. So you won't develop the allergic reaction to the vehicle that packaged the mRNA or the mRNA itself. It's a different technology, and that's the Johnson & Johnson one. It's only one shot, and it's very, very effective, almost 100% in protecting against death, basically. We know COVID-19 can kill people, but if you got one shot of the J&J, you're not going to die even if you get it. But even before then, it's very effective in protecting against just the disease itself, even mild symptoms. Hope that answered your question, Jane. Okay, we got another question here. Okay, well, thank you for your compliment. I'll just read it for the healthcare heroes here. Kudos to each of you in rising to meet this challenge. The toll on staff in all areas is unimaginable. What has been your sense of what HR and staff support measures are the most effective in helping staff with burnout? Thank you, Mary, for that question. I'm going to turn it over to Rob and then to Carol Ryan to take a crack at this question. Rob?
I don't know. I'm gonna have to probably lateral this right to Carol, because I got to say, for we ended up not reaching out to HR particularly much. A very tight family feeling in the emergency department, and we kind of took care of our own wounds and counseled ourselves through most of the tricky times. We certainly had openings to HR and also to employee assistance programs, which were made kind of readily available. People may have taken advantage of those, but we didn't end up with a system-wide HR response to our burnout needs, thankfully. But maybe Carol knows something more about what the staff upstairs had.
So particularly in the ICU and also in, I believe it was the intermediate unit, the Department of Psychiatry, actually, we had a psychologist, and he actually met with the staff several times. Then they did also meet with him. Several people would meet with him on an individual basis, and that seemed to be very helpful. It was very active during the first surge. Probably not as active during the second surge, even though I think that there was a need. I think that the staff seemed to be, they had this resilience in taking care of, and kind of fearless tenacity in taking care of the patients. And I think that they actually, through the first surge, were very strong and really had uh, the the mental behavioral health capacity to fight through. Having said that, I think that that probably leads to a lot of the exhaustion, of which now, as things have calmed down more, I'm making sure that I and my director team are extremely visible and are holding many more staff meetings on the units and being able to really talk about what the needs are and their suggestions. So we are really ramping up our shared governance team, something that we have not been able to do in the last year. So I'm hoping to get some more suggestions on really what the staff feels would be helpful for them now.
Thank you, Carol. Maybe you could provide a short answer to this. How do you feel about the 25% of your staff that chosen not to get vaccinated?
Hmm. I'm conflicted because I would say that as, one of the frontline people, that we were all out, as Rob said, every day as we're building biocontainment walls, and we're out talking to staff, and we're all wearing scrubs, and we're, we were all fighting the same fight. I know that staff, as I said, some staff are appearing to really change their minds about the immunization. I think there have been some fears out there with staff, particularly of childbearing age. And I think that some of those questions are now being answered. So I think that people are now feeling more confident, seeing that, their colleagues have been able to, receive the immunization and be protected. While I think it's a difficult piece for me to really understand, I respect their opinion. But I'm hoping that we can, in time, change their minds into really feeling safe to be able to get the immunization.
Thank you, Carol. I'm going to try to answer this next questions or two. I think they're related. First one is from Jody. Did it surprise people in the medical community when Coach Ariyama tested positive after his second doses of the vaccine? Great question. I'm going to get back to that. Related to it is a question from James. How long after the first vaccination would a booster be necessary? My understanding, this is what I read in the news. I didn't talk to Coach Ariyama, but I understand that he tested a positive 3 or 4 days after the second shot, right? So let me just tell you what we know about the protection by the immune system. 2 weeks after the first shot, you are really doing pretty good, but maybe 70–80% protected. Okay, that means you still have a lot of risk, and that's why you need the second shot, right? So after the second shot, it takes about 2 weeks for your body to develop the fullest immunity that the vaccine can produce, which is 95% efficacy. So my thinking is that, again, this is my speculation. We didn't do any research on Coach Ariyama, but I think 3 or 4 days after the second shot, your body hasn't had the time to fully develop that immunity, which will get you at 95% protection. It takes 2 weeks after the second shot to get at that. So to me, that means, you know, even though you got the shots, doesn't mean you are home free. I mean, even after 2 weeks of the second shot, you still have 5% chance of getting the virus, right? But if you get it, you won't get severe disease. My understanding from reading in the news is that the coach did not have any symptoms even, so which is an excellent sign. And and the other question is the booster. The booster is again, you know, that's why we wanted to study this. How long does the antibody last? We are conducting the study now. We're going to have some 200 healthcare workers who agree to get their blood drawn at 2, 4, 6, and 12 months after the vaccine. So we will have some answer for you, hopefully in the not too distant future. And we're accumulating those data now. See, I got another question. With the surge in Europe and Italy closing down again, are we opening up too soon? Well, anybody wants to answer that?
You know, I think that that is a really good question. I think that there are concerns out there about opening up too soon with, you know, the variant strains out there. And I think that's why we have not here at the hospital changed any of our masking policies or PPE right now, because, you know, the virus is still out there and we have to be able to wear our masks, to be able to wear our shields when we're patient facing at any time. So I think that is, you know, I think that's something that we're going to have to watch. I think our governor has been very proactive throughout the pandemic and really on top of things. And so I think that if he is fearful of, you know, anything changing, watching the prevalence, you know, rates, I think that in percentages, I think that, you know, he will drill back.
Yeah, I agree with you, Carol. As a healthcare worker as well, we still need to be cautious. We're not home free yet, and we want to be careful not to have another surge because we open up too soon. So I completely agree with you. And thank you, Evelyn, for that excellent question. I'm not seeing any more questions or answers. And we are 10 minutes past the hour. And I wanted to thank the panelists, the speakers, for having such an excellent presentation and then discussion. I also like to thank Liz and Samantha and Peter Lamont working behind the scene to make this happen. And without them, this would not have been possible. And so with that, thank you for those of you who attended the session, today's session. And this concludes the series of 3 panels that we have conducted since January. And wish you all the best of luck, and please stay safe. And I'm going to make a plea that you all get the vaccine. It's very safe. Don't worry about it. We need to vaccinate about 75% of the population to achieve herd immunity, which means the virus have no place to go. So eventually they will just die. And because enough people have the immunity, we can protect the whole population. So we're going to need you to have every shot in the arm. And I can't let you go without making that plea. So thank you very much. We'll talk to you soon.
Thank you.
Thanks,
all.
everybody.
Good night.
Bye.